Welcome back to Your Health radio and television program. I'm Dr. David Morwood. I am a board-certified plastic surgeon, and I'm so pleased you could stay with us for our next segment. We have the very illustrious, terrific plastic surgeon, Dr. Doug Sunde. Dr. Sunde, thanks for joining us.
Thanks so much for inviting me.
Dr. Sunde, my first guest, as you know, was Dr. Melanoma. He's an oncologist, and we discussed the treatment of melanoma and diagnosing it, et cetera, et cetera. And you are a board-certified plastic surgeon, and we're also going to continue our discussion of melanoma. So let's talk about why is it, or how does a plastic surgeon become interested in the treatment of melanoma?
Well, melanoma is a skin cancer. There's three main kinds of skin cancers, which Dr. Melanoma told us about: the basal cell carcinoma, squamous cell carcinoma, and melanoma. And it's one of the skin cancers we treat. Often when we excise or cut out the melanoma, there are big holes in the tissue, and we have to fix those holes.
So is it correct to say that if someone wants no scars, or they want the results of their surgery to be invisible, they can go to a plastic surgeon? Is that an accurate, or can I say that that's true? Is that a good reason to go to a plastic surgeon?
Well, I wish we could make no scars. You know, that's always our goal, but with plastic surgery, we try and minimize the scars, and we do that in a number of ways. We try and put scars in hidden places. We try and put scars in natural lines so they'll be more hidden, and we use fine sutures and delicate technique to try and minimize scars. But unfortunately, whenever there's a cut, there's a scar.
Well, I heard that. I heard a rumor. One of your patients had no scars after a facelift, and no one could tell. Is that accurate to say that?
Well, I think that that's probably very complimentary, but it's probably not exactly accurate in that people say there's no visible scars because we place the scars in places where people usually aren't looking.
Okay. So, Dr. Sunde, a rough estimate, how many melanoma operations do you think you've done, say, in the past 5 years?
I think I do between 30 and 50 per year, so between 150 and 250 in the past 5 years.
Well, that's a great experience. That's a huge experience, and we're lucky to have you around to help take care of these people. But let's review. When the diagnosis of a melanoma is made, let's say by the oncologist or by a dermatologist, what's the next step? What does that patient need once the diagnosis of melanoma is made?
Well, we actually are very fortunate in this community to have people who are very involved with melanoma and do a lot of melanoma. The typical thing is people go to their primary care doctor or a dermatologist. The dermatologist is an expert on skin diseases, so they're an expert at telling which moles look normal and which moles look abnormal. They biopsy it, which means they take a small portion and send it to the pathologist. And the pathologist is the one who looks at it under the microscope and can actually tell if it's melanoma or just a mole.
Okay, now that leads me to an important question. I'd like to teach our audience about this concept of margins. When we say that we need a 2 millimeter margin, or we need a 2 centimeter margin, or the margin is not clear, or the margin is clear, what's that concept? What do we mean by margin?
A margin usually means an edge. So when we cut out tissue, for instance, if we cut out a piece of tissue and we said the margins were clear, that means the edges where we cut out the tissue was clear. If we say the margins were positive, it means the edges of the area where we cut out still had cancer on it, which would imply that there might still be cancer left in the body, and we would have to go back and do more.
Well, why is it then that in certain skin cancers, now you mentioned that there's the three common skin cancers, there's basal cell, squamous cell, and melanoma. Why is it that sometimes for basal cell carcinoma, we won't require a very wide margin, but for something like melanoma, we're more comfortable with at least 2 millimeters or sometimes over a centimeter? Isn't that true?
Correct.
Now why is that?
Well, we think basal cell carcinoma is a very common skin cancer. It's the one that people have all the time when people say, oh, my grandfather went to the doctor and had a skin cancer taken out. It's usually a basal cell carcinoma. Squamous cell is a little more aggressive, which means it has a little more potential to spread to other areas or even other parts of the body. Relatively small chances, but some. And we have to take a little more tissue to make sure that we get a few cells which may be scattered around the tumor out. With melanoma, it's a very aggressive tumor, and so the deeper the melanoma is, the wider the area we have to take out so we clear out all the melanoma cells.
Well, Dr. Melanoma, my prior guest emphasized that in the early stages, melanoma is a curable disease. Is that your experience, Dr. Sunde?
Correct. And I think that what I was going to say is we've got really a great team of melanoma surgeons here. The plastic surgeons, like yourself and I, excise melanoma. Dr. Stuntz works with us closely in taking out lymph nodes and excising melanoma. And I think we've been extremely fortunate in our area to have an expert like Dr. Eftimi come join us, because he's just a fellowship-trained expert on melanoma and has a huge amount of knowledge about melanoma.
Well, Dr. Sunde, I appreciate that. I appreciate you saying that. Now let's back up for a moment. You mentioned Dr. Stuntz or another general surgeon or cancer surgeon will oftentimes sample a lymph node. Now, could we talk a little bit about what we mean by a lymphadenectomy and also what we mean by a sentinel node dissection?
Oh, I'd be happy to. So with the body, the lymph nodes act like filters in the body. So what happens is that the most common things people would say is, like, after they've had a cold and they get some swelling in their neck, that's from the lymph nodes filtering in the area. And so it's the same thing if you have a cancer. Sometimes the cancer can spread into the lymph nodes, which are the filters. And so what we want to do is we oftentimes want to identify if the cancer has spread to the lymph nodes, and if they spread to the lymph nodes, how many lymph nodes they've spread to.
But now I think it's important to emphasize, just as Dr. Eftimi mentioned, and emphasize that melanocytes are found in every person, and it's healthy to have melanocytes. They make melanin, and it's also healthy, normal, that we all have lymph nodes within us, actually hundreds throughout the body. Isn't that right?
Correct.
Now, just because a lymph node gets enlarged, that by no means is pathologic, and it certainly doesn't mean they have a cancer. Isn't that right?
Same as if you had a cold and you had enlarged lymph nodes in your neck. It doesn't mean you have cancer. It doesn't mean that's bad. It just means they're enlarged and doing their job.
Right. So there's, as you said, there's filters, hundreds of filters throughout the body that help to clean and maintain the bloodstream and filter infection or sometimes cancer.
Correct.
Okay, so let's again return to the patient who's had a melanoma or a mole biopsied, and the dermatologist says, yes, this is malignant melanoma, that the pathologist reads it under the microscope and then refers that patient to you. So then what does that patient need?
So the patient comes in, and at that time the pathologist, the one who looks under the microscope, has determined how deep the melanoma is, which is very important. The deeper the melanoma is, the more likely it can spread. So as you and Dr. Eftimi talked about, we love it when patients catch these early. And I always tell the patients it's the dermatologist's picture they should put over the fireplace, because the dermatologists are usually the ones who catch these early, and by catching them early, we can cut them out and typically cure them.
Okay, now Dr. Sunde, does everyone who's diagnosed with melanoma get a lymph node dissection or a sentinel node dissection? Actually, let's talk about that for a little bit. What do we mean by a sentinel node?
So a sentinel is like, when I think of it, it's like I think of 1776, and I think of a sentinel out looking for the British to invade. And so it's the first node. It's the one where everything comes to first. So we think that there's a definite pattern in the lymph nodes where it comes to a first node and then it goes to a second and third and fourth. In the old days, we had no way of identifying which node was which. So we would just take them all out. The problem with that is that you'd be removing the filters, and sometimes it would cause the lymph flow to back up, and you'd have problems with that. Oh, about 20 years ago now, a guy named Dr. Morton developed this technique using dye and then using some other techniques where he could follow where the lymph flow went to and actually identify which was the first lymph node, and they call the first lymph node the sentinel node, like the one looking out for the British.
So for example, if a woman has breast cancer, there might be a sentinel node dissection to determine if the breast cancer has gone to a certain lymph node, say in the armpit or even under the ribs. And if someone has a melanoma during certain stages, we might want to know if the melanoma went to a certain sentinel lymph node, correct?
Correct, and the great thing about the sentinel lymph node is we found out that if the sentinel lymph node is clear, then almost always the other lymph nodes are clear. And if the sentinel lymph node has cancer, then we have to go back and take more lymph nodes out. But what it's done is instead of taking all the lymph nodes from everybody, now we only take the lymph nodes from the people who have cancer, and the people who don't have cancer in their sentinel nodes, they're able to keep all the lymph nodes, and they don't have any problems then afterwards.
Well, I see. Dr. Sunde, that's great information. I appreciate you teaching this to our audience, whether they're listening or viewing. I want to talk about a few things specific to surgery and the plastic surgeon. I know there are a number of ways that you will remove a melanoma, but perhaps more importantly, there are a number of ways that you'll close up the hole or the defect, right? Now, could we talk about what we mean by a primary or complex closure? And I want to talk about what we mean by a graft and what we mean by a flap. So these are all tools that the certified plastic surgeon has to not only, well, I should say after removing the melanoma, to close up the hole or defect and try to minimize the scarring or deformity. Isn't that right?
Correct.
So let's talk about what we mean by primary closure in a complex fashion. And I want to talk about a graft, probably a skin graft, and I'd like to also talk about a local flap.
So what we do is after we cut out the melanoma, there's tissue missing. So we have to figure out how to put it together. If there's a lot of loose tissue, we can close it together. And sometimes we have to lengthen it to make it smooth, like a seam, like you would sew. And so we have to lengthen the scar, usually about 3 times as long as it is wide, to make it smooth. And then we put stitches in the deep layers, and then also the top layers, to try and have it be smooth and maintain smooth. And that's what would be called a complex repair. Sometimes in areas where you don't have extra tissue, you just can't pull it together. There's not enough tissue. So for instance, on your ear, or on your nose, or other areas where there's just not a lot of extra tissue, then what we do is sometimes we put in a patch or a graft. And what a skin graft means, we take skin from one part of the body and we move it to another, and then the blood vessels, through a miracle of the human body, grow into it, and it comes back alive.
So that's a skin graft, where we actually take skin from one part of the body and put it somewhere else. Now I recall from being a senior resident in the burn unit that oftentimes a burn victim will undergo skin grafts, right? But those are usually in big sheets, and we usually did split thickness grafts, and then there's full thickness grafts. Can you explain the difference?
A split thickness graft is like if you had your door and it was sticking. Sometimes we can take a tool and just shiv off a little bit off the edge of the door to make it so it closes nicely. For the skin, we do the same thing. We can take an electric tool called the dermatome and just slice off the top layer of the skin and move it to another area, and then it'll regenerate at that site. There's some benefits to that, and is that you can cover more areas and that the area where you took it from regenerates. But there's some downsides, and it doesn't look as good, it's not as thick. When we take a full thickness skin graft, the full thickness is the entire thickness of the skin. We usually take that from an area that has extra, like your thigh or your fold where your leg meets your body. And then we take some out there, we can close up that hole, and then we have an extra piece of skin, and we can move that to another area.
So those are 2 different types of skin grafts, what we call a split thickness skin graft, and we actually shave off the top layer of skin, and the new skin grows from underneath, and we take that split graft or split thickness graft and apply it somewhere where there's a pretty big hole that we can't close primarily. Or there's a full thickness graft there where we actually take a piece of skin, close up the hole, and then move that skin to somewhere else.
Correct.
Now what about a flap? What do we mean when a plastic surgeon does a flap?
Well, there's a bunch of different flaps, but usually a flap means instead of counting on the area to supply tissue, to supply blood to the tissue we bring in, a flap has its own blood supply. And it can either be a local flap, which means through some geometry tricks of plastic surgery, we could take an area which has a little bit extra and move it over to an area that doesn't have as much and just kind of rearrange things. I always tell the patients it's like a magic trick. Or we can take an area from another large piece of tissue from the body called a free flap, where we take a large piece of muscle typically and blood vessels and skin and move it. Those usually we don't do for melanoma. We do those usually more for things like breast reconstruction, where we need a very large volume of tissue.
Well, Dr. Sunde, I don't mind letting our audience know that I've been very lucky, fortunate in the past few years to be able to work with you and do microsurgery. And oftentimes when we take a big chunk of tissue from one part of the body, we can actually do an auto-transplantation, right, with that microsurgical flap, or what we call free flap. And we actually plug the vessels in under the microscope to the recipient area, or where we need the new tissue. Isn't that right?
Well, that's what's so incredible, and we call it transplantation. People think of transplants like heart transplants, and with a heart transplant you get someone else's heart and they sew it in, and then you have to take drugs so your body doesn't reject it. With a free tissue transfer or free tissue transplantation, you transfer it from one part of the body to another, but you don't have to take medications because it's your own tissue.
Right. And Dr. Sunde, I don't mind letting our audience know you're terrific at that microsurgery, and we're lucky to have you around. So let me back up a moment to talk about the primary closure of, say, a defect from a melanoma, or even a basal cell or a squamous cell. Oftentimes in my office, if I have someone, say, with a defect of the forehead, I'll have them raise their brows and I'll make some drawings. Or if they have a defect of the cheek, I'll have them exaggerate a smile, and then I'll make drawings in a different vector or in a different way. I bet you do the same thing. Can you explain to our audience why, for example, on the forehead we might want to close horizontally, but on the cheek we might want to close sort of obliquely? Can you explain that?
Well, we try and do it. Again, part of plastic surgery is, although we'd like to wish we could make invisible scars, we can't. But we like to hide the scars, and usually the best places to hide them are in these relaxed skin tension lines where the muscles fold. So if somebody has creases in their forehead, we could do that there. If someone has a crease in their fold here, we can do it there. And a lot of times if they have wrinkles or creases here, we can put the line in, and so over time as the scars mature, they end up with a line that mimics a normal aging line.
Well, Dr. Sunde, it sounds to me like in your practice, and I think as a board-certified plastic surgeon, you will oftentimes combine your approach, your reconstructive approach to, say, remove a melanoma, with your cosmetic approach to try to minimize scar and deformity. Is that accurate to say?
Well, we think as plastic surgeons that's a great strength of ours, is that we can combine the form and the function together. And so we do facelifts, we do tummy tucks, we do cosmetic surgery, and we also do reconstructive surgery. And the principles from both work to help the other side. So the cosmetic surgery principles certainly help the reconstructive patients, and often the reconstructive principles we learn can help the cosmetic surgery patients in how we move tissue and realign tissue and those kinds of things.
Well, Dr. Sunde, just a couple quick questions. We only have about another minute. Now, I know you do a lot of what we call Mohs reconstruction, or cases that the dermatologist with special training will remove a skin cancer and then refer to you. Now, can you talk briefly about Mohs, and does the Mohs dermatologist operate on melanoma?
Typically, the Mohs dermatologists operate on basal cell carcinoma and squamous cell carcinoma. Not many operate on melanoma, and the reason it's difficult for them to tell because it's a different kind of skin cancer if it's all clear when they take it out. So most people do not have Mohs surgery for melanoma, although that's an evolving concept, and in some areas they do have that.
Well, Dr. Doug Sunde, you are board certified by the American Board of Plastic Surgery, I'd like to emphasize. Now, if someone has some questions about melanoma or any other type of cosmetic surgery or reconstructive surgery, can I give out a phone number perhaps where they can call?
Sure, they'd be happy to call. My number is 372-0200.
And you're right here in Monterey?
Correct.
Dr. Doug Sunde, board certified plastic surgeon. We're lucky to have you on this peninsula, Dr. Sunde. Thanks so much for being my guest on the program, and I hope you come again.
Thank you very much. I really appreciate it.
I'm Dr. David Morwood. I am also a board-certified plastic surgeon, and this is Your Health radio and television program. We're going to take a very brief pause for a very good cause. We're coming right back.